So let me give you just a little bit on this one. So there's a lesion here, and yes, I'm just showing you there is no hydrocephalus. This patient comes after a few years, and now we have this. The patient has hydrocephalus, and that lesion is bigger. No, it's up to, so both of these are T2 weighted images.
Okay, sir. Sir, I can appreciate that there is an abnormal signal intensity DN in the involving the right cerebellar hemisphere and part of vermis. And it is crossing the midline, and it has hyper-intense signal with internal hypo-intense septations. And in comparison with two images, this lesion has significantly increased in size and causing a pressure effect on the fourth ventricle with the proximal hydrocephalus. And no perirenal edema is noted on this image. So this is a cystic lesion with internal CSF signals with multiple internal septations.
These are flare and T.
Okay. On flare sequence, there is a suppression of the signals, which are hyper intense on T2, and on T1 weighted image, probably it is plain without contrast. And it has iso-intense with mixed hypo-intense component.
Okay, so what's your differentiation?
Okay, sir, it is an intra-axial cerebellar mass in an adult patient. So my differential will be okay, so it can be any cystic tumor like Medulloblastomas, cystic astrocytoma.
As far as for the cystic is concerned, you see here the flare.
Yes, sir.
So it's not suppressing here, and here is the T1, and I don't see fluid signal here. So it is not cystic lesion. It's very bright on T2. Every bright lesion is not cystic. Right. There's some cystic areas, but the whole lesion is not cystic.
Whole lesion is not cystic. Okay, sir. It can be, sir, astrocytoma, glioma, ependymoma. It can also be ependymoma.
Okay.
Which is heterogeneous.
Okay.
Yes, sir.
So, as I said before, I apologize in advance. Some of these cases may not be your board cases, but all these are very typical. And once you have seen these lesions, hopefully you will remember them when they come next time. Okay. So if I go here, so this patient lesion has this pattern, what we call corduroy pattern or striated appearance. If I go back, see here, see all these lines. So this is a striated pattern. It's a corduroy pattern. You know this lesion which has the corduroy pattern?
Sir, central neurocytoma, I can remember, but it has lace-like pattern, not like striated pattern.
The central neurocytoma usually in the third ventricle?
Yes, this is in the third ventricle. So, sir, I cannot rightly remember at that time that which lesion has this striated appearance.
Yes. So this is a Lermite-Duclos disease. It has a very classic appearance. No other lesion has this kind of appearance. So if you see a cerebellar lesion which have a striated pattern or the corduroy pattern, these don't enhance. And so this is a kind of a, you can call it, some people call it cerebellar dysplastic gangliocytoma or a hamartoma. So this is Lermite-Duclos disease.
Lermite-Duclos disease. Sir, what is next in this? I mean, that what will we do next if we find this?
This depends on, most of the time they don't grow, they don't do anything, so you just observe them. Like just this patient, it became symptomatic, then you need to do something.
So I'm presented with axial sections, flare images taken at the level of centrum semiovale and the lateral ventricles. In these images, I can see intra and the extra cerebral CSF spaces are dilated. Moreover, I can see certain hyper intensities are noted in the centrum semiovale and in the periventricular white matter, which are almost symmetrical. And moreover, I can see. So,
these are the only two images. What do you think the diagnosis is?
So if I consider this volume loss and these periventricular hyperintensities, then this could be the ischemic changes,
okay,
as in the old patients, okay, or microvascular ischemic changes. Other possibilities could be if the patient is on chemotherapy, it could be post-chemotherapy liquid encephalopathy,
okay,
or if
So you think there is a volume loss and patient has some white matter
yes.
changes. Okay,
Yes.
one more image. Is that helpful? It's a T1 coronal.
It's T1 coronal. Yes, in this image, I can see there is effacement of sulcal spaces in the centrum semiovale, while these spaces are prominent in the inferior, like sagittal, and the rest of the images, these are prominent.
Okay.
So there is relatively less volume loss of preserved brain volume in the superior sections, like in the frontoparietal superior white matter preserved. So this is actually the focal atrophy of bilateral temporal and the parietal lobes.
Okay. So
it could
have
be
you heard of symptoms of, if the patient present with the symptoms of 3Ws, are you familiar with 3W symptoms?
Yes, sir. So it's normal pressure hydrocephalus.
Yes. So this is, so it's not an atrophy basically. There is some. So I gave you this image. So there are many signs. I will tell you what the most two signs I use for it. If we look at here, Sylvian fissure is big, all the sulci are big, the lateral ventricle is big. Right on this image, when I go at the surface of at the vertex, I don't see that. So based on these two images, you can suggest the patient has NPH. And this one clearly show you. Some people are like, they think the Sylvian fissure is big, the patient has atrophy. So this is a kind of a part of this disease. The Sylvian fissure will be enlarged, basal cisterns will be enlarged, ventricles will be enlarged, and the sulci at the vertex will be effaced. So that is one sign. And the second sign is the callosal angle. I will show you in a second. So this is the NPH. These are all different signs. People use Evans index. I'm not going through all of these. Aqueduct stroke volume, they do the cysternography. I will tell you what two things I use. So the first thing, as we already said, in NPH, there will be effacement of the sulci at the top. In the atrophy, we will see the sulci. So that is one sign. Second sign, if you look here, in the atrophy, the ventricles are falling like this. In the NPH, the ventricles come like this. So here is the callosal angle which you measure along the ventricle. So if it is less than 90, that is acute. So in this patient, it is 63. In this patient, it is 130. So these are the two signs which I use like my everyday practice. So effacement of the sulci at the vertex and a narrow callosal angle. There are some other signs too. So another practical tip, whenever you think the patient has NPH, make sure the patient does not have a web or something obstruction in the cerebral aqueduct. This is a normal person. The cerebral aqueduct is patent. So this is not an NPH. So this patient has a web. In NPH, we have enlargement of the third ventricle and the lateral ventricle. So same thing happened with the cerebral aqueduct, this web. So in all those patients, so make sure there is no web. Other thing, if you do the routine T2 weighted images, actually you will see a hyperdynamic flow. See here is the CSF. It should be bright like this. Why it is dark? It is moving. It is very fast moving. It's like a hyperdynamic flow. Okay. So whatever points to effacement of the sulci at the vertex, narrow callosal angle. So that will be our NPH. These are the CT image, one with contrast, one without contrast.
There is a well-defined hypodense lesion at the gray and white matter junction in the left cerebral hemisphere, in the left frontal region. It is showing peripheral post-contrast enhancement, but there is no definite perilesional edema, and no internal soft tissue enhancing component, no evidence of calcification. There are other similarly enhancing lesions are noted at the gray-white matter junction involving anterior aspect of left frontal region and the lateral aspect of the right parietal lobe. The lesion in the parietal region has a significant perilesional edema associated with it. But there is no midline shift. I can also appreciate a few hypodense lesions involving the deep white matter in the left cerebral hemisphere as well. These are representing edematous changes.
Yeah, so what is your differential for these in ring enhancing lesions?
As these are multiple ring enhancing lesions, I'm thinking of infective focus like tuberculosis. Okay. Others is multiple ring enhancing lesions also indicate presence of cystic metastatic disease.
Okay.
Other differentials will include active phase of neurocystic sarcosis.
Okay.
And so some granulomatous lesions like fungal infections, they also present like ring-enhancing lesions.
Yes. So that's good. Your differential is excellent. So out of all of these, is there any feature here which favor one of them, or there is no specific feature?
So as the surrounding edema is disproportionately more as compared to the size of the lesion, so I'm thinking more of the METs. Also, these are at the junction of gray and white matter cortex. It again goes in favor of METs.
Okay, let's see the MRI here. These are T2 and FLAIR.
Okay, in T2, these are cystic lesions with surrounding edematous changes. On FLAIR, the internal fluid is suppressed, but the surrounding pathological edema is appreciated. So I'm thinking of metastasis.
This is pre and post.
Yes. So in post-contrast images, again, there is ring enhancement and no internal soft tissue enhancing component. Meninges are showing normal enhancement.
Okay. Diffusion weighted image.
In diffusion weighted image, the one of the lesion at the left occipital lobe is showing restricted diffusion. It is hyperintense, and corresponding ADC is showing a low intensity signal.
Okay.
So all of the lesions are showing restricted diffusion.
What about this here? Does
this no. Only the peripheral part is showing restricted diffusion. Central part is not.
You gave all the pertinent finding except one. So what is your diagnosis now? Metastases or something else?
So in ring in tuberculomas, the central part will not show restricted diffusion. Only the peripheral part will show. Okay. So this DWI is more in favor of tuberculomas.
Okay. So let's go back here. And now I will highlight some of the points. In this lesion, if we just have to imagine, there is an eccentric area of enhancement.
Okay.
Other feature on these lesion is, so these are at different stages. This is bright on FLAIR on the T2, no edema. This is not that bright and has edema.
Okay.
This one is enhancing. There is an eccentric nodule enhancing. This has different signal as compared to the other one. This lesion has a different signal. And similarly on the diffusion, they have a different signal. So there are two very particular points here which you can pinpoint to one diagnosis. What do you think?
So demyelinating lesions, as these are at different times.
Have you seen demyelinating lesion, multiple ring enhancing? Usually they are, what kind of ring enhancement they have?
So they have incomplete ring enhancement.
So what about
so these are complete ring enhancement. So other differential is toxoplasmosis.
Okay. So that's what you gave all the finding, you gave all the pertinent, you mentioned your all the diagnosis. These two feature that there is an eccentric enhancement, yes, and the stages are different. Yes, so this is neurocystic sarcosis, okay?
Okay.
So this enhancing eccentric nodule is the scolix.
Okay.
And in the neurocystic sarcosis, there are different stages. Let me see if I can. Let's see how somebody can delete this line. So this patient also had a lesion in the psoas muscle. It is T1, here is T2, and you can see it is also has a ring enhancement. So these are different stages. You can read from the book. But the teaching point in this case is, if you have ring enhancing lesion, they are of different stages. So these are like they're dying. One is like a live parasite, some is in the different phase of their degeneration. So this is the only disease which usually does it. So again, if you have an eccentric enhancing nodules like a scolix, okay, and if you have a variable phases of the lesion, some have diffusion restriction, some don't have diffusion restriction, so that will be neurocystic sarcosis. These are the two T2 weighted images.
Yes, sir. So this is MRI brain axial slices of 30-year-old male, and there is an intraaxial lesion in the right temporal lobe with multiple cystic hyperintense signal giving a bubbly appearance, and there is no surrounding edema and no mass effect and no midline shift. So based on these, and these are coronal slices, T2 weighted images and FLAIR. Again, I can see there is a lesion in right temporal lobe with a bubbly appearance, and it is cortically based.
T1 pre and post.
The T1 and post contrast show the lesion is iso-intense on T1 and does not show any post contrast enhancement.
Just a little bit dot here.
Yes,
Okay. So what do you think? What's the differential diagnosis?
My diagnosis is DNET, and differential include ganglioglioma.
Okay, that's good. So you did great. So that is exactly what it is. So this one is DNET. And the ganglioglioma, usually they have a solid component and a cystic component. They have calcification, and then they also have a enhancing nodule. So as you use the correct words, so you got the full box, bubbly intracortical lesion. Usually they don't enhance, but sometimes they can have, and they present with epilepsy. So again, if you have a cortical bubbly lesion, that is just DNET, okay?
This is MRI brain of 30 years old female, and there is a lesion in left parieto occipital lobe.
Okay.
And this is showing hyperintense signal on T2 and FLAIR.
Okay.
And this is intraaxial, no
Okay.
mass, no midline shift.
Okay.
So
here are the more images. Almost looks like the same. Here are more images. This is a very difficult case. It is a very something new classification. You already passed. You did with the flying color. I just want to see if you know this one, then you got the distinction. What do you think on this coronal image? This is something, if you have seen, you know it. If you have not seen, you will not know it. So let's see. So this lesion, as you said, T2 hyperintense. If you look at the periphery, there are tiny nodules, like one here, one here. And if I go here, you can see all these little tiny nodules here. There's a one here, one here, one here. They don't enhance. And you can better see on the diffusion weighted images, these are sometimes they become coalescent and sometimes they are separate. So this is called MVNT, multinodular vacuolated neuronal tumor. I just put this here. First, you have a cortical bubbly lesion, that was DNET. And this is bubbly lesion like deep cortex or the subcortical white matter. This is MVNT. And here is a companion case from Radiopedia, and you can see that it's a bubbly cystic lesion, but not in the cortex. Okay. So if it is in the cortex, DNET. If it is in the subcortical white matter, it is MVNT.
okay.
If I tell you this lesion is coming from the clivus, clivus has two parts, basis sphenoid and basi-occiput. So this is coming from the basis sphenoid part.
Basis sphenoid, yes, sir.
So what will be your differential?
It could be a chordoma.
On what basis? Is there any particular feature which suggests chordoma, or what the other differential will be?
Sorry, sir, I can't hear your voice.
So is there any particular features which suggest it is chordoma?
Sir, no, sir, no typical features. No typical feature of chordoma is there. Next differentials, it would be. Sorry, sir, I can't remember at that time.
So you did well, and I will go a little bit fast through the images because I have too many cases. I just want to share all of them, and all of them has a teaching point. So, so let me go back to the first CT image.
Yes.
So here the lesion is, the margins are well defined. Okay. So when the margins are well defined, so the clivus lesion can be metastasis. You can have a plasmacytoma. You can have lymphoma, chordoma, chondrosarcoma, some other lesions.
Yes, sir.
If the margins are well defined, that is a little bit against lymphoma as well as metastasis. The well-defined margins are more seen with chordoma. So that is one feature which favor chordoma. So if you give some diagnosis, you have to give all the pertinent points. So this one feature favor chordoma.
Yes, sir.
And then this feature, this lesion is very bright on T2, even if it looks like brighter than the CSF.
Yes, sir. Yes,
so
sir.
that bright lesion, which is solid and enhancing some, there are only two lesions which can be that bright.
Yes,
you know what those two lesions are?
Sir, in the brain? So
right here, right in this location. much bright enhancements. Either they could be chordoma or it could be chondrosarcoma. So this lesion is in the midline. So that feature favors chordoma over the chondrosarcoma. So right now we have two features. It has well-defined margin. It is light bright on T2. And diffusion, if you look at the ADC here, it is kind of bright. So it's not that much diffusion restriction here. This feature is very particular. You see here as it's causing the impression on the pons. This is called thumb sign. Have you heard of that? So it is like a thumb pressing on the pons. Have you heard of that term?
Yes, sir.
So here is this patient. So this is the lesion. It is pressing on the pons like a thumb. And here is the thumb from the radiopedia. So hopefully everybody will remember this sign from next on. So what are our feature? Well-defined margin, very hyper intense on T2, and there is a thumb impression, okay? So that is your chordoma.
Thumb. Thank you, sir.
Thanks.
Sir, these are the multiple sections, slices of MRI, T1 and T2 images, axial sections at the level of maxillary sinuses, in which I can see that abnormal MR signal intensity area evident in the petroclival area, which is hypo on T1 and subtle showing hyper intensity on T2, and it is expansile involving the petrous part of the temporal bone. Sir, can I see further images, sir?
What do you think based on these images?
Sir, it is T1 low, T2 high, some bone, some lesion involving the bone.
Okay, so here is the diffusion.
On diffusion weighted images, I can see that it is not showing diffusion restriction, sir.
Okay. This is the pre and post.
Yes, sir. On post contrast, it is homogeneously hyper intense, sir, homogeneously showing contrast enhancement and expansile involving the both parts of the petrous part of the temporal bone. However, the adjacent vessels appears normal to me, and it is encroaching up to the base of the nasopharynx.
So you have an expansile lesion in the clivus. So what is your differential diagnosis?
Sir, in my provisional diagnosis, as it is not showing much contrast enhancement, some homogeneous contrast enhancement, petroclival parts, not T2. Sir. So squamous cell carcinoma of posterior part of nasopharynx, sir.
This lesion is in the clivus. So
okay, fine, sir.
If we go here, this is our nasopharynx. If I
yes,
go
sir. It is pterygoids. All these appears normal to me.
This is the mucosa of the nasopharynx, which is normal. So this lesion is in the clivus.
So, sir, in clivus, I would like to see its bone window on CT. Otherwise, yes, sir. Now it is expansile and involving the reaching up to the posterior part of the. Yes, sir. Sir, it is showing ground glass like opacity involving the petrous part of the temporal bone, and it is expansile with thinning of the cortex, sir. And ground in my provisional diagnosis is fibrous dysplasia, sir.
That's good. So just a point for this case, what is the teaching point in this one? I show you the last case, and that was on the spectrum of bright lesion, very bright on T2, just like a light bulb. Light bulb. Yeah. And this one is dark, okay? So
yes, sir, it was not high on T2.
This is on the other spectrum. At the same time, if you see the bone is not destroyed, it is expanded. So once, if you have a dark lesion on the T2, I will show you many other cases. To me, the darkness on T2 is very important because most of the lesions are bright. Brightness on T1 is very important because more of the lesions are T1 hypointense. So whenever I see this kind of a difference, those are usually very helpful. And other point is, if you have a bony lesion ask for a CT. And if the bony lesion is dark like this, you can have a dark lesion. You know what are the causes of dark lesions on T2?
Sir, dark lesions must be, sir, calcifications. And calcifications are, sir? Sorry?
They can be dark. What else?
Sir, sclerosis should be dark on the T2. And calcification should be dark on T2. Retinoblastoma, melanin, sir.
Melanin can do anything. Okay, what else?
Okay, fine, sir.
So the tumor which are very cellular, like
fungal,
like a lymphoma, they can be dark on T2.
So and fungal.
So yeah, that's good. You already gave the answer. So if you have a lesion which is dark on T2 and I want to see it is a cellular or not, I have to look at diffusion. So I looked at that's why I gave you the diffusion here. There is no diffusion restriction, so it is not hypercellular, it is not lymphoma. By this you can rule out lymphoma. So lesion which is dark on T2, we cannot tell it is hypercellular or not. It can be. If the lesion is dark, it can be. To confirm that, we look at the diffusion. So if the diffusion is restricted, then that is hypercellular. So here the diffusion was not restricted. So our lymphoma was out. And here it enhancement. And again, as we can see here, the bone is expanded, the cortex is thin, it is intact. So that is your classic fibrous dysplasia.